Very good. Thank you again for the invitation. Let me quickly get into telling you what I'd like to present, which is the value of mortality studies. COVID has had one consequence, at least which I would call as positive, is an attention, a media attention to the basic fact that we're not counting the world's dead completely and reliably. If there's about 60 million deaths and about 50 million of those occur in low and middle income countries, then approximately half of those are effectively uncounted. Either the information on if the person died and if what the causes of death were is just simply missing. And this was a major gap during COVID. So what I'd like to do is talk about nationwide mortality studies, and I'll start by giving you my conclusions, which is that they are essential for documenting avoidable mortality, both in young life and in middle age. And I'll give you three examples. One is malaria mortality in India and in Sierra Leone, suicide mortality in India and Ethiopia, and vascular mortality. Moreover, it is possible in limited ways to study key risk factors, and I'll give some examples particularly from India. And finally, since we're hopefully on the completion phase, I wouldn't say it's behind us, but looking at COVID deaths and the substantial difference in excess COVID deaths in India and versus in Sierra Leone, despite uncontrolled transmission pretty much in both settings. So to start with, just going back to 1990, when the Millennium Development Goals started and were broadly adopted shortly thereafter, has seen extraordinary improvements in mortality at premature mortality at different ages. And one has to look at these by age-specific patterns. So at ages 0 to 14 in low-income countries, shown in the yellow, you see an incredible decline, such that it used to be 23% of children born in low-income countries in 1990 would be dead before their 5th birthday, and that's now down to 9% and continuing to fall. And this is dead before their 15th birthday, excuse me. And you see that the difference between high-income countries, shown in the blue at the bottom, and low-income countries has substantially narrowed and quickly narrowed. This is just unprecedented. This is why we think, well, this is kind of the golden era of global health because of this attention. And at ages 15 to 49, there's also substantial progress. That first bump that you see very much reflects the impact of HIV/AIDS, which also has been brought under control in many settings. If we go to older ages, 50 to 69, then this pattern is slightly less optimistic. We see declines at all ages, right throughout those age groups, but the rate of progress has been far slower at 50 to 69. If one considers an older population, 70 to 84, which is becoming increasingly relevant to countries thinking about what to do with the elderly and the healthy longevity agenda, there's actually quite good news in high-income countries, shown in the blue, where you've got a reduction from 60% to 40% in older age mortality. But in low and middle income countries, far less progress. So the core of trying to understand what is possible at different ages is to have good information on causes of death. Well, what do you do when deaths really occur at home and without medical registration, such as in India? India's got 10 million deaths approximately a year. 7 million are registered, but only 1.3 million are medically certified. And this varies both by state, the poorer states having the worst registration and medical data, but also by gender. Females are more undercounted than males. So one solution is actually one proposed well over 140 years ago by the sanitary commissioner from the government of India, who, working with peers around the world, proposed this idea that for sanitary purposes, it is indispensable to know the relative mortality in small areas to ascertain the death rates and to see how far they arise from preventable causes and to apply the remedies. That effectively is the design of the Indian Million Death Study. So what we've done since 2001 in India is working with the Registrar General, who have a complete sample of the whole country. Approximately 1% of all the houses and all the villages or the urban blocks in the country are enrolled in this continuous demographic survey. And we send 900 non-medical staff that have been trained several times to get which I'll define as a verbal autopsy, which mostly involves standard questions and a good local language narrative that is then used. They did this work on paper, now it's moved to electronic. And then at the end of the day or end of the week, the data are uploaded. And we have online 400 doctors coding, and they're strictly monitored in terms of what their guidelines are with adjudication. And the idea is to study all diseases, keep things really affordable. And currently we're at 800,000 deaths. Million deaths will be reached by next year after the disruption from the COVID, because the field work was disrupted. And importantly, this simple solution is now expanded to Sierra Leone, Ethiopia, and elsewhere, and I'll show you some results from those. So what is a verbal autopsy? I think most people are familiar with this, but it is worth emphasizing because clinical judgment, sometimes the criticism of verbal autopsy is simply what the family said, and that's what you write down. That's not actually the case. A verbal autopsy involves a structured investigation of signs, symptoms, and events before death. It's based on the WHO instrument, and the interview includes a local language narrative of the events in chronologic order. I like to think of it akin as to much in the medical training when you first saw as an intern a patient, the guidance was don't rush to a diagnosis, try to figure out why the patient is in front of you. What were the symptoms? What were the things that brought them to the hospital? And then discuss that with your colleagues to try to get a diagnosis. So we tell the field staff, don't make a diagnosis, get a history and figure out what is the key of the symptoms. And by metrics of how well it's worked, it's reasonable that what you have is the ill-defined deaths, which is a crude measure of the quality of the medical certification, was much, much higher prior to this system being introduced than after. It's about 4% now at 5 to 69. At older ages, there's still considerable misclassification, but it is lower. But this is a phenomenon that actually Richard Dahl and Richard Pito addressed in their landmark book in 1981 about misclassification of death certifications in older ages. So for what it's worth, when the Queen Mother died at age 101, the English death certificate cause of death was of extreme old age. So it really would be a non-defined or ill-defined cause in that case. One broad proof that we've got is, since there's no gold standard for verbal autopsy, this has been the criticism, what's the gold standard? Well, you really can't compare people who died at home to those that died in hospitals because they're qualitatively different in terms of distributions of disease and particularly of infections. But we can think about a silver standard, which would be, what if physicians went out and did verbal autopsy and coded their records and coded or had their records coded by other physicians. And if we compare that to lay non-medical staff doing the same houses, what would be the comparability? So as part of a randomized trial, we did this, and we found actually it was quite good. The non-medical staff were finding more or less the same causes as medical staff. So this application has now gone to Sierra Leone in partnership with Rashid Atsimana and Ronald Marsh and others. And to tell you some of the conclusions from this work, and this is just round one of the work, it provides a stable platform for getting good cause of death data. I think we've shown that in a pretty definitive way. We knew from the UN population estimates that Sierra Leone has very high death rates. 63% of Sierra Leoneans die before age 70. And we demonstrate here that mostly that's from preventable or treatable causes. And the big finding is that malaria was the leading cause of death in every age group except neonates. The other major finding is that the maternal deaths ratio in Sierra Leone, while high, was much, much lower than the World Health Organization. And to WHO's credit, just last year, they've now corrected their numbers to adopt more or less the Sierra Leone numbers. So these numbers have already influenced WHO numbers and kind of broadly global knowledge. So how does this study work? Well, we took the census population stratified to try to get higher or lower education areas within the census based on female literacy levels, and over-selected the poor areas. So that's Sierra Leone, the whole of Sierra Leone. The western area shown there in Freetown approximately contains half the 7 million population. The remaining are all over Sierra Leone. And so we have a distributed sample of something like 660 units now that cover the whole country. And teams go out to these once a year. And they're all using electronic verbal autopsies now. So there's teams of 4 go out. At the end, they synchronize the laptops, and one of them sends it to the cloud. And in the cloud, after some processing, they're available pretty much the next day for physician coding, which is also done online. So the physicians aren't interrupting their clinical work. This is their evening work. And then the idea is you can get from field work to cause of death in 8 days if needed. I mean, our typical turnaround is about 2-3 weeks, but we can do it in 8 days. Now, one of the things that we've been testing is because we have a system like this, electronic system, you can try to build in a lot more innovation. So we built in random resampling of the field work, built in other ways to really monitor the quality of the field work. And more recently, we've tested this idea that can you use ChatGPT or other GPT tools and see how well they compare against physician coding. And the answer is startlingly well, but the concordance seems to be quite good. Now that's an argument for saying you don't replace physician coding, but you could have ChatGPT enabled or assisted coding along with physicians to try to improve the quality. So to come back to the key findings, so this is, as with all papers, there's always one figure that really stands out, and this is the one from the Sierra Leone analysis. You see a U-shaped pattern of malaria mortality, and that's shown in the death rates per 100,000 in the black. And then what you have in the blue is the total probability of death in that age group. And then the orange is the contribution of malaria to that. So if I draw your attention to 45 to 59, it's 22% chance of dropping dead in that age range. And of that, malaria constitutes 3% absolute risk of dropping dead. It's quite high. And this just shows the contribution of malaria at different age groups. So at 15 to 29, it's the leading cause of death, about 20% of deaths. At ages 30 to 69, it's still the leading cause of death, 14%. And the period risk is higher because the death rates are higher. And then when we look at the malaria deaths that occur, a surprising number occur in those that actually were in a hospital or recently discharged. And a surprisingly low number actually received the relevant treatments or even had a malaria test. So there's real concerns about the quality of malaria treatment that might be contributing to this high mortality rates. Then you can use the data because they're geocoded to get a geospatial profile. And this gives you, at least based on round one, the red represents the hotspots of malaria. And particularly in Bo, where we have a lot of operations, which is shown here, and in surrounding areas, there's a fair amount of malaria. And that's also reported by the local clinicians. That's very much the malaria belt of Sierra Leone. This finding of a U-shaped pattern was also seen in our Indian data, first in 2005 using what is shown in the red, and then in the follow-up work in 2015 also showed the U-shaped pattern persisting. The rates have come down, but the U-shaped pattern continues to persist. More recently, the Indian government has accelerated malaria program efforts after really being quite unhappy with these results and threatening the lead author, Neeraj Dhingra, with all sorts of government sanctions through the Indian credit, the Indian government credit. They put Neeraj Dhingra in charge of the National Malaria Program eventually. And since 2016-17, there have been intensive efforts in the malaria states to actually control malaria. And one of the key things we want to look at is this U-shaped pattern. Has it actually diminished substantially, particularly at the older ages, because they're taking an approach of looking at all ages of malaria, not just child malaria. And I think the reason is because of this finding. It was unpopular and nearly got the whole project suspended, but it eventually led to some action, particularly in the malaria state. So just to mention maternal mortality, well, the WHO estimates, which were largely model-derived, were something like 1,100 maternal deaths per 100,000. Our study showed that it was still very high at 510. And in the latest WHO report, just issued 3 weeks ago, they've revised their estimate to 443. So the Sierra Leone government is very happy that, you know, the label that BBC had is the worst place to deliver a baby in the world is Sierra Leone. Well, it's bad, but it's not the worst. And this has led to a welcome revision at WHO. So let me turn to some of the results from the Million Death Study. And I think the key is that pretty much anything that we thought we would find, when you look at the data, you find surprises, very little confirmation of our presumption or of our presumptions. So this is just a list of some of the key findings, and I'll just focus on a few. And let me start with just a little quiz. So this is a distribution of a disease in different parts of India, showing, you know, an absolute risk from as low as, this is dying before age 70, from 0.25 all the way to 1%. Anybody want to hazard what the disease is? Okay, unfair question, so I'll give you the answer. Snake bites. Snakebite mortality is surprisingly common in India, about 58,000 deaths a year. And that estimate was what WHO had as its global estimates. And to WHO's credit, they didn't complain on BBC as they did with our malaria findings. They actually went and changed their estimates to about 100,000 worldwide. And more importantly, put snakebite on the neglected tropical disease project. And what we've done is being able to document where the snakebite deaths are concentrated have helped the Indian government think about a snakebite mortality program. Effectively, if they had antivenom that was geared to the different types of species, there's 4 snake species that are relevant in the high snakebite areas, you could actually substantially reduce snakebite mortality. And that's effectively been flat over a 20-year period, you know, constituting about 1.2 million deaths. So this again is spurring actions. And for those of you interested in snake bites, if you Google Ram Whitaker and BBC, he has just this hysterical video about how he works in Tamil Nadu, and he's been there his whole life. And he's got a hysterical video of what snake bites do in India. I know it doesn't sound like a humorous subject, but it's really, really quite interesting. It's Ram Whitaker, Whitker. So more broadly, in India, there's an extraordinary variation in mortality at different ages. So at 0 to 14, you see a north-south gradient, which has been well described. This poor states in central India are the ones that have very high child mortality. And if you try to explain why this variance across district, then actually just a few variables such as maternal education and childhood immunization levels explain most of that variation across childhood mortality. But for adult mortality, defined as 15 to 69, you see this unusual pattern. It's not so much a north-south gradient, but crudely an east-west gradient with these large pockets. And again, if you try to explain this variation by looking at variables such as maternal education or even smoking prevalence, some other indicators at the district level, there's very few variables that can explain this. So as with all epidemiology, there must be important determinants of intermediate determinants of risk or of causal factors that are common in some districts, but not in otherwise similar districts. So this is very much as an argument for blood-based epidemiological studies, which are now starting to occur. And I'll just give you one example of that, which is the variation in suicide. So Vikram Patel's work with us looked at the suicide death rates at ages 15 or higher. And you see this incredible variation, like in the South, the death rates are 20 times those that are there in Bihar. And particularly in women in Tamil Nadu, it's quite much higher risk than in the North. And why should this be? I mean, it's we really don't know why there's such a huge north-south gradient. What we also know is, at least in India, the age pattern of suicide wasn't what was conventionally assumed, including by the global burden of disease. They had taken data from high-income countries, which is shown in the dark line, and showing, well, basically suicide risks go up with age, probably as a result of repeat chronic depression and mental health issues and or alcohol use. And that's the same with men and women. But you see in India, the actual pattern was a peak in young women, and then it came down with another peak at older ages. In men, it's a bit more complicated. You have a peak at younger ages, but then a second peak kind of at age 40 to 45. We think that probably reflects farmer suicides, which were the dominant discussion point in that we thought, oh, suicides only occur among farmers in India. But up until the study pointing out, well, if there's 200,000 suicides and the number of farmers' suicides doesn't match that. This is occurring in young women and in men, typically at the time that they get married or enter the workforce. So the reasons for those aren't well understood. Now jumping over to Ethiopia, where we've done a similar study, and to our surprise, we thought, well, that'll also have a pattern of suicides peaking at younger ages, but in fact, you see that it goes up both in men and women, but particularly in men. And what is surprising is, again, assaults you would think injuries is a phenomenon among young people, or young adults, but in Ethiopia it occurs at older. For suicides, what was interesting in both places is that half were due to pesticide poisoning and a quarter due to hanging, both in India and in Ethiopia. And Richard might have shown this slide to you earlier, but this is a remarkable efforts in Sri Lanka, where effectively they banned or restricted access to pesticides, to hazardous pesticides from agricultural settings, and look at the decline in suicide death rates. So in both countries, a practical strategy to decrease suicides in India and Ethiopia would be to really take pesticide access seriously. So let me turn to vascular disease, which is the leading cause of death. And if you attended the Richard Dahl Symposium, I gave a presentation, and I think the conclusion of that is still the same, that we really don't know about why there's so much variation and reasonably high death rates in vascular disease in India. So there's approximately 1.3 million vascular deaths in middle age, 30 to 69, and mostly from ischemic heart disease, and mostly with a previous history of disease, which is important for secondary treatment. And in contrast to most other parts of the world, the risks of ischemic heart disease have actually increased. The risk of death has increased from 10 to 13% over this 15-year period, and 5 to 7% in women. Stroke risks have come down, but only modestly. And there's a unique pattern, a geographic pattern, which again is not fully explained. Ischemic heart disease tends to be concentrated in the north, in places like Punjab and Haryana, but also heavily in the south. Stroke has this unusual pattern of being quite common in eastern India, abutting onto Burma and to the Chinese border. And from the verbal autopsies, we're not able to determine whether these are hemorrhagic strokes versus ischemic strokes. But we do see that 1/6 of the population contains about 1/3 of all the national stroke deaths for reasons which are not known. And looking at the trends, again, you see that India, US, UK in about 2000 had all age ischemic heart disease mortality rates standardized for age about the same, but there's been a big divergence, declines in US and UK, but increases in India. For stroke, there's better news is that the rates have fallen comparably in India and UK, the US, but there's still a 3-fold higher age standardized mortality rate in India versus the UK, US, again, for reasons which are not well documented. And the assumption would have been that, well, perhaps this is an effect of urbanization, that people go from having leaner body mass and the rural areas to come to the urban areas, and they become fat and smoke more. But surprisingly, you see for ischemic heart disease, the increase was most notable in rural areas, and in urban areas, there was basically a flat trend in age standardized mortality rates. This might well reflect access to treatment, that phenomenon is occurring, that you're adopting increasing risks while moving to the urban areas, but it is paired with better access to statins and blood pressure pills and aspirin in the urban areas. For stroke, again, puzzling, we see increases in the high burden states, but not in the low burden states, both in rural and urban areas, again, for reasons which remain undetermined. So one of the things to examine is, well, could this be some changes in risk factors? And you've heard from Richard, Rory, and others, of course, the importance of the very known and established risk factors, smoking, blood pressure, adiposity. And let me quickly touch upon some unknown and emerging factors, because there's some newer evidence on these. And for particulate matter, I thought the key message I would convey to you is that it's not important for ischemic heart disease. So let me start with that. So what we did here is a retrospective cohort study where we went and got satellite information from NASA, which does these very careful satellite measurements, and they've really worked to make this publicly available, reasonably good quality data. And there's been groups that have validated those satellite measurements to ground measurements. So the PM2.5 exposures have really improved over time. And so we joined those satellite-based measurements to each of the areas, approximately 8,000 sampling areas in the Indian million death study, and did it in a prospective design. And then we looked at the excess in cause-specific mortality as defined by both physicians. So this was a strict criteria on what the cause of death was. And therefore, heart attack, for ischemic heart disease, you see that we have one model, a Poisson model, and we didn't do spatial adjustments, which is important because these diseases and exposures both cluster. You have to take into account some clustering in the statistical analysis. And effectively, there was no association. We did another comparison where you do injury controls. Injuries shouldn't be related to particulate matter, and there was really no association. For stroke, there was this puzzling finding where, in fact, stroke PM2.5 was protective, but then when you took into account spatial clustering, there was a modest excess. And then, of course, what you would expect is a dose-response relationship. So I'm sure you've seen the headlines that people in Delhi have so much particulate matter, it's the equivalent of smoking a pack of cigarettes a day. I mean, that's the kind of headlines that are being made. But when we look carefully at the relationship with higher levels of particulate matter and then the hazards, you see very little. It's basically flat. So the black represents our studies and the yellow is Salim Yousaf's pure study, sorry, the other way around, basically showing no dose-response association for ischemic heart disease. For stroke, there is a upward trend, but with some uncertainties. And both what you see are the dotted lines, which are the model-based estimates that the global burden of disease use. So the conclusion is that the model-based estimates, at least for India, are substantially overstating the hazards for ischemic heart disease, stroke. I didn't show respiratory disease, but it's very similar to the heart attack. If there's anything, there's an association with stroke, but these are very much at the limits of what you can do with epidemiology when you're looking at really small excess risks with still a fair amount of residual confounding. These are very much the limits of epidemiology in terms of what we can determine. So those, I don't believe those GBD model estimates really are correct for India, and they might not well be true for China and other settings. Okay, what about lacto-vegetarianism? This is kind of a unique exposure in India because you can study lifelong lacto-vegetarian. People basically are born into lacto-vegetarian families and stay that way. And what you see is the green represents the percentage who are lifelong lacto-vegetarians. So what we did here is an analysis where we took each of those 8,000 units and looked at people who are lacto-vegetarians or not, and then compared the cause-specific mortality. So each unit functioned as its own control, and therefore it took into account differences in local risk factors, local access to food, different types of markets, even particulate matter, although that's not important. And what did we find? Well, to our surprise, and some annoyance of all the people who would like India to become completely vegetarian, is that in fact there was no protective effect. There was a slight excess, 10% excess in men, excluding drinkers and smokers and using local controls, slightly higher in women. And when we looked at wives, it was even higher. So now why should that be? Well, our sense is that this is very much driven by not so much the protective effects of vegetarianism, but the lack of meat in the diet is a measure of lack of protein. And typically in a family in a rural area, who will eat last? It'll be the wives, and they'll have the least protein intake. So we think this is actually pointing to protein deficiency and not so much protection or excess risk from being vegetarian. Okay, on body mass and cardiac mortality, I think Sarah has shown you some of the puzzling patterns. Sarah Lewington's shown you what has occurred. But so this is South Asian men and women tend to have more adiposity than Europeans at any given BMI. BMI correlates beautifully with higher systolic blood pressure and diastolic, and higher blood pressure beautifully correlates with higher cardiac mortality. But higher BMI is not associated with higher cardiac mortality for reasons that really are not quite clear. So let me mention, I won't talk about smoking in detail, but what is unique about the Indian smoking patterns is how effective Indian men seem to be at killing themselves from smoking. So Indian men who smoke cigarettes lose now about a full decade of life. And that's comparable to populations where smoking starts earlier in life and constitutes a higher amount of cigarettes per day. And that's shown in this comparison. The top is the Richard Dahl's study from the UK doctors. Then it's Valerie Burrell's Million Women study. Those are prospective studies in the US in the middle, and these are Japanese atomic bomb survivors. So you see comparable hazards, even though Indian men smoke later in life and smoke less. And what is emerging when we look at the trends is that much of that might reflect a change from using the locally manufactured bidis to cigarettes. So what has happened over time in the observation periods is the hazards, even though the prevalence is going down, the hazards, smoker, non-smoker, are becoming more extreme. And at a Western smoking pattern of 10 cigarettes per day, you see hazards now 3.44 for cigarettes, but they have increased. So this is very much the strategy of the tobacco industry in India is to really try to get people to switch to cigarettes. And unfortunately, the government is helping them by not raising taxes enough. Well, a strategy to think about is really, can we monitor former to current smoking ratios around the world. This is actually a crude but very effective way of saying, you know, are you getting cessation at serious levels? So you study the age where smokers become serious about quitting or have become. And you see the extraordinary, the red is the good areas, and you see extraordinary improvements in Canada, US, Australia, parts of Eastern Europe. The African data are not so reliable because of not enough surveys. But look at Brazil. I mean, that's become a poster child for getting adults to quit. Where are the challenges for tobacco control? Well, they're very much in Asia. So that includes Russia, China, India, Indonesia, and other populations where most adults that are quitting because of disease, not to avoid disease. The other implication of this finding is treatment that, as mentioned in both the men and women who had cardiac disease, most of them recorded pre-existing disease. So it does suggest that there is a strategy for practicable secondary treatments with statins, blood pressure, and aspirin at least. The other implication is to try to get blood-based studies broadly patterned after the UK Biobank or the Chinese Kadoorie study. And Rajesh Dixit has set up once a study in 200,000 adults in one part of Maharashtra. And the plan is to extend this to about 5 sites to try to understand some of the key risk factors. And let me turn lastly to COVID, because the key question here is, if you've got uncontrolled transmission, what happens to mortality? And the Indian scenario was effectively a disaster. So COVID was the main contributor to the huge increase in excess deaths. The cumulative totals that we estimated were about 3 million just during the Delta wave of April, May 2021, or mostly during that time, which is 7 to 8 times higher than the official reported. And that number accounts for a big part of the global numbers of missing deaths. So WHO's recent estimate published in Nature said perhaps there were 15 million COVID deaths over the last 2 years, but only 6 million actually recorded. So there's 9 million missing COVID deaths. So India accounts for a big part of those. So the Indian mortality, or the Indian COVID pattern, has been really characterized by 2 big waves, not multiple waves. So the first one was kind of an alpha with some other infections thrown in, and the big increase that occurred in April, May was of Delta. But there's also been parallel a huge and quite successful rollout of vaccines.
I couldn't read the dates at the bottom of that. Could you just say what the dates were of that big wave at the end?
This effectively was from started early April 2021 till about June 2021. And then that peak that you see here is approximately September, October of 2020, that first one. So this is an example of ill-placed hubris in decision making. So after India had that first peak and didn't have a huge increase in deaths, it led effectively to the Prime Minister saying, well, you know, India has licked this. We've taught the world how to lick this virus. And he said it in February, and even vaccines were becoming available, and many people stopped saying, well, I don't need the vaccine. The Prime Minister has said we're good. And along came the Delta wave, and the health system was so overwhelmed. I mean, I'm sure you have seen the absolute horror stories. I was corresponding with Sumit Biswas, who's the BBC reporter based in Delhi, and he was saying it was unimaginable for a few weeks how bad things were, even with the resources that were available to him. So now we ideally would want to count on the million death study results, but they were suspended to get the census underway in 2021, which has been suspended on its or postponed for the same reasons. And the registration data, as I mentioned, were quite patchy. So what we decided to do is work with a very reputable polling company, C Voter, who had set up random digit dialing over all of India. India has very high mobile phone coverage, and they get reasonable participation rates. It's not 3% like in Canada or US of people who will take phone calls. They got about 53% of people to agree. And they have the ability to do the random sample, so you actually create a profile of the census, which is actually quite good. Now, this main study was of 140,000 adults, but the definition of household deaths wasn't as good. So we did a sub-study where we had a better definition of household deaths. And what would you find? Well, what's shown here is the proportion of houses that reported a death. And the dotted represents the expected number, which is about 3% of houses should report a death in the last month over time. And the variation there is from the million death study. So you see what would be the kind of monthly variation. And then in the blue are the reported COVID deaths with the right axis. And the red is what did COVID tracker report for just COVID deaths. So you see a small peak in September, October of 2021. About 1% of houses reported a COVID deaths compared to 3% from all causes. So still that's notable. Look what happened in April, May, that just COVID deaths reported in the house were well over 5-6% for several weeks. And that's well in excess to any death expected. When we looked at the sub-survey and very simply were able to ask who was alive in January 29, who died, and then look at the death rates, you see them before you. So in 2019, the crude death rate was 7. It's more or less what is estimated by the UN of 8.1, a little lower. By 2020, it had gone up to 10.5. By 2021, it is 18.4. So colossal short-term increase. And then when in this survey, we were able to ask whether people thought it was a COVID death or not COVID death, which is shown in the blue and red. And the key is that there was an increase in both deaths, both COVID and non-COVID. So we looked also at the civil registration data that was limited. And the third source, actually, we went on the Ministry of Health's website and they have this monitoring study of 200,000 health facilities where they're reporting deaths weekly. And this is publicly available. So we went and looked at this data. And what you see here is the background rates in 2018-19, shown in the gray, and then the peak in September, October of shown in the orange. And the blue represents what was happening in 2021. Now, when this came up and they got wind that we were analyzing the data, they shut it down. So we couldn't get any data after May, but they underestimated the persistence of one of our statisticians and working with Ariel Karlinski said, well, we've taken the data down, but maybe if we just go on the website and instead of putting in the URL April 2023, what happens if we put in May 2023 and June 2023? Sure enough, it was all there. So we were able to get data for the subsequent period. So just to summarize, what do these mean? Well, from these studies, just if you look at the last column, it's the excess deaths that occurred. If India has 10 million deaths a year, then what was the excess? Well, it was between 26% to 30% excess, so between 2.6 to 3 conservatively. WHO's estimates are even higher. They think it's about 4 million deaths. Now, to get into the details of the facility data, because I think it's informative. So this is now, we look just at the states which seem to have pretty good rural coverage with their facility level data. So this is 5 states: West Bengal, Chhattisgarh, Andhra Pradesh, Karnataka, and Tamil Nadu. And so what happened here is in the blue, the emergency inpatient cases, when the national lockdown was announced with 4 hours, you see a huge decrease in people going to the hospital. But notwithstanding that, the facility deaths showed these 2 big peaks, one in September, October of 2020, and then the big one during May, June of 2021. If we look at causes that should not go up during, then in fact there was a decline in accidents and burns, And in suicide, they came down, but you see they've come back up after the lockdown period. Tuberculosis, although concerns that TB care was substantially affected, actually continued its secular decline. But for every other cause, and the cause definition here is not very ideal, but the key is the patterns that occurred. So again, the national lockdown occurs. Basically, every other cause that could be attributable to COVID went down. And then you see there's a small peak in September. And then look at the colossal peak at all causes, however you define them: cardiovascular diseases, fever-related, known chronic, respiratory, unknown causes is the big one. So these data confirm that there was a big excess in rural areas, not just in urban areas. So the Indian government was really quite unhappy about this. They put out a press release saying, this is, they really disagreed with this. I was worried they were going to cancel my visa when I planned to visit. Thankfully, they didn't. And they put out a bunch of evidence to say, well, this study is all wrong. But when they put it out, the study, all the things they actually did actually confirmed our findings. So one was that when they released the civil registration data for 2018 and 19 versus 2020, they said, oh, see, there's no excess. Well, their excess of 11% is very close to our excess of 9% in WHO's for 2020. They've yet to release the 2021 data. I don't think they'll do it until the next election because it's going to be a very touchy subject for the current government. Another source of data was the medically certified cause of death. So again, for 2020, this is not the big peak. They had a 9% excess deaths, very similar to what we have. The claims of life insurance, because people could claim life insurance claims for COVID, was actually quite comparable. So my sense is that after the election, there will be a fair accounting of the huge excess of deaths that have occurred. And that is important because these are, again, the WHO totals of cumulative COVID deaths. So that's the reported in red. That leads to the 6 million figure of reported deaths. And then the blue represents the excess deaths. And you see that there is variation. And India accounts for a big part of those missing deaths. What's next for COVID work? Well, what we've recommended to the Indian government is on the 2024 census, they place a simple question, which is, was there a death in this house since January 2022, or January 20? And then if yes, you get the age, sex, and date, not worrying about the cause. And that actually as a strategy is practicable for many censuses around the world to get a direct accounting of the effects of COVID. So the UN Statistical Division has recommended that, and hopefully many governments will take this up. I'm not optimistic the Indian government will because it's pre-election and they won't want this kind of data, but it is a practical strategy. Now, I'd like to quickly, in conclusion, contrast. I'm sorry, I forgot to mention one key point. Let me go back here, which is by the end of that first wave, seroprevalence studies in India showed, at least in the urban areas, 60–70% prevalence of the infection. So this was the paradox. It was widespread infection, but reasonably low deaths. And this in part contributed to, and no vaccinations at that stage. So this contributed to the sense that, oh, Indians are super immune, nothing can kill us, and we're good to go ahead with life as usual. And they were completely unprepared for the Delta wave. Now, by contrast, what I'd like to do is to show you in Sierra Leone, in the same areas that we've worked in, we took urban Bo and now rural Bo, took the randomly selected areas and sent teams to go back to those houses and collect dried blood spots. So the first round of work was done in July, August 2021. That was exactly during their Delta wave, and but also happens to be their malaria wave. And so of these, we randomly selected 224, and I brought them to Canada, smuggled in my luggage, so we could get them tested at Mount Sinai labs with a very good quality set of assays, and a subset underwent neutralizing antibodies. And then we also tested a cohort that was after the April, or it was in April 22. And here's the key results. It's a little bit busy, I apologize, but if you look at the three antigens, nucleocapsid is the one that's most noisy. And sure enough, you see that when you look at historic malaria samples, there's some cross-reactivity there. But interestingly, more with the malaria negative than the positive. Receptor binding domain and spike, if you look at the very strict criteria, they were both positive. The first round in the Delta wave showed close to 70% prevalence. And if you look by age group, it was actually at all ages. By age, by April, by the Omicron variant, it had gone up to 84%. And then in a subset, we looked at neutralizing antibodies to say, well, are these just kind of minor infections, or are they enough to trigger significant antibody response? And yes, in half, they were quite significant. And when we looked at the persistence, it wasn't the case that people just got infected and lost the immunity. Most of them retained positivity. So this is the Sierra Leone reported cases, which obviously are going to be underestimates. And you see in the blue, the reported cases and the rolling 7-day average. And in the red are the deaths in the HEAL-SL study over that time period. There's some reporting problems with the deaths, but when you look at this pattern, there really is no major excess of mortality. There might have been a bit during the alpha wave, but really no excess. When we looked at facility level data, and now we're getting census data and civil registration data, they seem to point to a common pattern that while infection was very widespread in Sierra Leone, deaths were not. And now the question is why? The obvious explanation that has been raised is, well, compared to India, you've got a younger age structure, less adiposity, less chronic disease, less diabetes. Is that the explanation? I don't think that is probably the major one, because when you look at older Sierra Leoneans, and then in our mortality data, when we look at those that had chronic disease, you'd expect, well, it was going to knock them off. The excess during the peaks versus the troughs would be in those with chronic diseases, and we don't see much evidence of that. So what is it? It's and one of the questions that comes in is, what are the correlates? Effectively, the infection acted like a vaccine, meaning it didn't provide particularly good protection against infection or reinfection. You see here that from Delta to the Omicron wave, still 20% of people got infected. But it provided very good protection against mortality. And are there cofactors, perhaps even including malaria, that prevent someone from dropping dead from COVID, but don't prevent infection? So this now is leading to an Africa-wide network. We're looking at differences in malarious and non-malarious areas and trying to establish the mortality in those areas. But that in turn would depend on having much better mortality data in all these settings. So let me conclude again that nationwide mortality studies are unpredictably useful. They both annoy and support governments in interesting ways. And I hope I've shown you those with 3 examples. There is the scope for doing more limited risk factors. And if we think about pandemic preparedness and what is needed to move forward, I hope one of the lessons from all the press coverage is we need to count the dead and describe causes reliably. So all of our papers are up on our website. So if you have any questions, you can look on the website, or you can tweet me at Count the Dead. Thanks very much.